Can we explore the complexity of VTE a bit more? What kind of issues are we dealing with, and what is post-thrombotic syndrome?
It's something that's worth discussing, because I think often people forget about the complexity of treatment, and I tend to think about it in three different phases. So I think acutely, when we think about the complexity of VTE, is to do with the selection of the initial anticoagulant. And ultimately, it's not quite as clear cut as just saying we've got one treatment that we can put every patient on. There's differences in terms of the provoking factors for VT, in terms of the locations of VT, in terms of patient factors such as renal function, weight, antiphospholipid syndrome. So the first complexity is in choosing the correct anticoagulant. The second complexity is in how long do we treat these patients for, especially in terms of the fact that we know now the VT recurrence rates are higher than we maybe previously thought. And so far more now we're assessing patients even after first-time events for lifelong anticoagulant therapy. So again, that requires a specialist knowledge to be able to make those decisions. And thirdly, and which is what you just touched on, is that long-term risk of complication. And you mentioned the term there quite rightly, which is post-thrombotic syndrome, which I'll just briefly give you a background to. So around about 30% of our DVT patients will go on to develop post-thrombotic syndrome, which is essentially where patients have the long-term symptoms of VT, despite them not having recurrent thrombotic episodes. So patients will often have long-term leg swelling, cramping, pain. The difficulty with it is that there's no known effective treatment or cure for it. And so much of it comes down to patient expectation management and maybe things like stockings that can help to support them. But as I mentioned, a third of our patients will develop this. So we have to identify that. And hence, at the point where we're discharging patients, we have to do a lot of awareness with them and management of expectation around the resolution of those symptoms. Similarly, when we think about PE, the long-term complication of PE is CTEPH, or chronic thromboembolic pulmonary hypertension. So again, this can be quite a disabling condition whereby you have chronic clots within your lung, developing high pressures within the right side of your heart. And as I mentioned, a lot of these patients have long-term dyspnea, and their performance in life is greatly reduced. Again, we can look for this. We undertake echoes in our PE patients, and we have specialist pathways we can refer to respiratory when patients are deemed to be high risk of this. But again, I think this is maybe one of the advantages of having a centralized, specialized VTE service, is that we can undertake all those roles and ensure that all three of those key elements are being completed for every patient we see.
Much more to it than you might at first think. What impact did the introduction of direct oral anticoagulants have? But many of us thought that this would make it all very easy by comparison with warfarin.
Yeah, yes and no. And I think from a patient perspective, especially, I think it's made it far more straightforward. I think we're now seeing patients being able to, take to be able to take anticoagulant therapy with minimal impact on their lives in terms of, less monitoring, less dietary impacts, less interactions with other medication. And to an extent, there's an advantage for us because, as I sort of alluded in this story almost, I think previously with warfarin, we'd spend so much of our time invested in the drug and how to monitor it and how to load it, that maybe we lost sight of the other aspects that I just discussed. Whereas with DOACs, they are far more straightforward to initiate and to manage, and hence we do have far more time now to look at these other complex matters. And also, we've seen the data, the bleeding data, especially in long-term patients, is very positive. And I think that now, because we're far more comfortable with the idea of using long-term anticoagulant therapy, we are seeing far more people with first unprovoked VT going on to receive lifelong anticoagulant therapy. Whereas I'm not so sure we would be as comfortable with warfarin. But you're right, they're not quite as straightforward as they seem. And there's so many nuances to their management in terms of the background conditions people that have, in terms of the site of the VTE. Not everyone can have a DOAC. And again, I think it supports this idea of specialist services, is that we need individuals to be able to identify the correct patients. And as I mentioned, I can't see why that can't be a pharmacist.
Could you give me an example of a typical VTE patient, and how would the service work for them?
So generally, as I mentioned, at this moment in time, the patient be diagnosed by a medic at present, referred to us same day. That initial consultation is all based around the selection of the correct anticoagulant regime. We do that on day one. Then the subsequent reviews would be based mainly around establishing the patient's compliance and tolerance to the anticoagulant regime, undertaking all those investigations I mentioned, such as echoes, and whether there's any additional things such as thrombophilia screens that need to be undertaken. And it really comes to that 3-month review, because that is where we make the decision, we're continuing lifelong or we're stopping. And so much of the sort of discussion around that's undertaken at the 3-month review. And then once we've made a decision, patient gets either counselled if they've stopped, or they get referred to their GP for ongoing management.
Thank you. That's a very useful point about the importance of review.